By then we'll get more people.
Yeah. I think, or else, take it. I think we give a brief introduction and start the slides.
Yes, you can start off.
I think that would be better because, yeah, lovely. This is the good evening, everybody. Come in. Just what we thought. This is the second edition of our Pulse NutriQuiz. I'm sure people who have participated in the first edition really found it quite exciting, and at the same time also quite good, significant learning process. And this particular NutriQuiz module primarily is designed in such a way that we will have a very interesting case which is being presented. And in between the case, we will be taking a particular gap and then we will be sharing our questions to be answered for the contest. And these questions and answer would be coming through an application called Slido. And how to use this Slido and how to answer the questions faster. There are two criteria primarily. One is the correct answer. The second one is the fastest finger first. Both the things would be considered to identify the winner primarily for every round. At the end of every round, we will be also in a position to tell you or showcase the leaderboard to see that who are all there on the top 5, primarily contesting for the awards on this NutriQuiz contest. Okay, before I move further and introduce today's topic and speaker. Okay, let's go ahead straight away do that. Can we have it on the presentation mode, please, in the regard? Before we introduce the speaker and the topic to you, I think maybe it is worthwhile. I think, Saurabh, you can play that video as to how Slido app need to be really downloaded and logged in, and then how they'll have to attend the quiz. Over to you, Saurabh.
Yes, sir. Sir, instead of video, I have made a step-by-step guide on how to join the quiz platform for the people who are attending from Zoom, and also for the people who are attending from YouTube. So this is for the participants who are joining from Zoom. The quiz link will be shared in their email IDs as well as in the chat box. From the chat box, they can simply click the quiz link, or they can join from the email ID. The quiz will be shared in their email IDs. This is for the people who are going to join from YouTube. The process will be same. Either they can join the platform by clicking on the quiz link, which will be shared in their email, or we will display the QR code. They can scan the QR code. The third way of joining is they can go to slido.com, put this number 1069, which will be displayed here.
Or can we also share it in the chat box, the link?
Yes, sir. Yes, sir. Yes,
that would also be done. Correct. They can quickly access the chat box and download that. Yeah.
Yes, sir.
Go ahead. Sorry, sir.
No worries, sir. So once they click the link, they will be redirected to the quiz platform, where they need to enter their full name as it should appear in their certificate, and the email address. The email address they will use, which they have registered, with which email they have registered for our program today. They will use that email ID, and they will click on the join Slido. As soon as they do this, an OTP will be received in their email ID, in the registered email ID. They need to put that OTP or access code in here, and they have to just click on the confirm. This is on the step 4. You can see the way how they will get the access code from here. So they have to put in it. Here they will put and click on the confirm. After that, their name will be automatically fetched since they have already entered their name after clicking the link. So they have to simply click on join. As soon as they click on the join, this step 7 screen will come on their desktop. screen, and they have to wait until the moderator will start the quizzes from their end. They do not have to refresh or go back to any other tab. They need to just wait. Once the moderator starts the quizzes will appear as it is shown on step 8. So they have to. Yes, sir.
Sorry for interrupting. There are a few people are writing in the chat box link. I think they got the link now.
So
For
the
the
link
quiz
will be
link.
shared to their mail and the email ID during the presentation. Once the presentation will be started, then in the flow it will be shared.
So I think you got the point. Yeah.
Yes, sir. They might get confused between the Zoom link and quiz link if we share it at the same time.
Right. Thank you.
So once they will select their correct answer, they will simply click on the send. And after 5 set of questions, they can get back to the meeting or the presentation, case study presentation. And once when we have another set of questions, then it will be introduced and the same process will be same. In the chat box, the email will be already, joining link will be already there. They can simply click it. They do not have to do any access code or anything. They will be directly redirected to the quiz. I will start the quiz from here. Then the questions 6 to 10 will appear, and same for the 10 to 15 questions. The link will be shared in during the presentation.
Okay, thank you, Saurabh. Is there anything else you would like to add, Saurabh?
No, sir, that's all for how to join the
Fantastic.
quiz
Thank
session.
you. In case of any other this thing, because many of the people who have attended the last time, it will be easy to navigate. For the people who have come in, it's nicely you have made a presentation and you have shared. Thank you very much, Saurabh, for doing that. Now we will move on to the presentation and the main part of the program in this regard. And please, can we have the slides, please? The first slide on the topic as well as the speaker. Yeah. Is it the full this thing? Okay. Good evening once again, everybody, and I'm sure you have understood the process of this Slido, and it's a great pleasure for me, whom I knew right from the start of my career, almost more than 2.5 decades ago, Dr. Aritra Khan, whom has evolved significantly, primarily right from the stage I met him. Today he has come to that level of getting the doctorate, at the same time also continuously moving on in the learning process. It's a great pleasure for me to talk to you briefly about Dr. Aritra Khan. Can I have the next slide, please? By the way, today's topic primarily will be on the clinical nutrition challenge, decoding a complex cardiovascular case. So we're going to really talk about a complex cardiovascular case. I think I request everybody to pay a lot of attention because Dr. Aritra Khan has spent a lot of time with a lot of passion. He has prepared this particular slides to make this learning more memorable and significant in this regard. Okay. Can I have the next slide, Saurabh? Yeah, of course. Thank you, Saurabh. I think the others, I would request them to mute their mics so that whatever we speak, it is clear and audible to you. Here about Dr. Aritra Khan, he is a PhD and FCN, founder and director of Aritra's Diet and Nutrition, primarily from Kolkata. He is a Lifeline Diagnostic Center cum nursing home. He has been working with them in Kolkata, and he's a head of the department of Honorable Chief Dietitian for Lifeline Diagnostic Center cum nursing home, Kolkata. For 16 years, I've seen him actually working in some of the many important and the leading hospitals, along with the many of the leading opinion makers of the eastern region, some of the gastroenterologists and some of the intensivist where he has been working around in this area, and over 16 years of experience in clinical and therapeutic nutrition. He has advanced specialization in bariatric nutrition. That is something quite interesting. And special interest in critical care nutrition, diabetes education, bariatric surgery, cardiology, and renal nutrition. He has specialized in all those subjects. He's academic. He's also an academic counselor and examiner of IGNOU in New Delhi. So I extend a very warm welcome, Dr. Haritra Khan, and I request you to, from here on, take the proceedings and make the presentations primarily on the topic of our Pulse NutriQuiz today. Thank you. Over to you, Dr. Haritra.
Thank you so much, Ramesh sir. It's a lovely introductions about me. I'm really deeply honored and sincerely my heartful gratitude for the Pulse Nutritions for introducing me such a lovely way. And yes, I know Ramesh sir since a long, I think more than a decade about this remarkable journey. I'm really very much privileged that in these organizations are doing so many things, advancing from the clinical and the critical care nutrition, lot of evidence-based empirical studies and really very much confidence about their journey regarding the clinical and critical care nutritions. And really I'm very much honored and elated once again for inviting me such an wonderful journey and the quiz competitions, because something should be quiz is very much kind of a what I can say goosebumping kind of thingy. There are a lot of attractive and lot of lucrative prizes are waiting for us, and that too only after hearing a presentation. So all the answers are hidden in the presentations. If we can mitigate all those things, we can get some lucrative prizes. So without any delay, I'm going forward to the presentations directly. So
Yes.
can I request Saurabh to go for the next slide, please? So meanwhile, the presentation is coming. So there is a very cardiometabolic and complicated cases that we will discuss today evening. And there is the critical cases like medicine, like medical nutrition therapy, lot of challenges, lot of drug nutrient interactions, lot of biochemical parameters here and there. Lot of fallacies are there. So accordingly, we can make some questions. So meanwhile, will log in the quiz window and you can join directly from the Slido quiz slides. Okay. So what's this all about of today's topic? Today's topic is basically a case of type 2 diabetes, hypertension, heart failure, like we used to call congestive heart failure, and severe hepatic steatosis.
एक कौन सा फ्लेवर है
Yeah. Steatohepatitis and the hypoalbuminemia. So you know very well, yesterday we did discuss about World Hepatitis Day, where we did discuss that Hepatitis Day shouldn't be wait for anything. So we can start from the day 0, and not only the clinical treatment, but also the medical nutrition therapy are the key parameter holistically to approach for making a tailor-made medical nutrition diet. That is very important. And simultaneously, previously what we did called about like NFLD, non-alcoholic fatty liver diseases or non-alcoholic steatohepatitis, but the paradigm shift has been changed. Today, we do discuss about much more of the MASH, that is metabolic associated steatohepatitis. We all know very well that steatohepatitis means there is steatosis, like fat cells in the liver and fat accumulations in the liver. But previously we did discuss about the alcohol, non-alcoholic fat, anything. But nowadays, if any metabolic syndrome like obesity, overweight, or ABCD. I think you all know very well what is ABCD. ABCD basically adiponectin based chronic disorder. So in obesity, we do discuss because nowadays obesity itself a disease. So obesity oriented steatohepatitis and MASH are very common. And you know very well what is heart failure. Heart failure means when heart is not pumping properly, when the ejection fraction is less than 40%, we used to call the heart failure with reduced ejection fraction. So these part are very common, and simultaneously there are lot of medication like sacubitril valsartan, lot of concomitant medication, albumin trajectory, and medical nutrition therapy, which is our primary subject to discuss about these things. Next slide, please, Shora. So I think this picture you all know very well. What is renin, angiotensin, aldosterone system? I'm not going to dictate and I'm going taking a class on these things also. But this means that you know very well lung, liver, heart, kidney, all are well connected with each other. So all the disease, there shouldn't be any kind of primary disease. There a lot of disease are comorbid with each other. Lot of disease are interconnected with each other, and there's a multidisciplinary approach that we can see a patient. Okay, so integrate the cardiometabolic, hepatic, renal, inflammatory, nutrition's data into one clinical problem solution and design fetched MNT of the adequacy, metabolic control, liver health, and the lean mass preservation. Evaluate the gradual albumin improvement alongside their C-reactive protein, edema, ascites, intake, output, fluid balance, positive, negative, clinical recovery, and apply evidence to the advanced dietitians MNT based quiz questions. So this about all the agenda of today's evening. Next slide, please. Yes, so here is a case of a patient, 56-year-old male, old Indian male, most certainly, 170 centimeter height, 92 kg body weight, and waist circumference is 108 centimeter, where BMI is 31.8 kg per meter square, and central adiposity is there. If you see the vitals, there's blood pressure 154 by 94 mm of Hg, and pulse rate is 88 per minute, and hypertension, symptom dyspnea, orthopnea, fatigue, ankle edema, what is basically we can call the pedal edema, and poor appetite, interpretation, congestion, and the nutrition risk, where we have done the echocardiography, 2 dimension with the color Doppler. We can see the left ventricular ejection fraction is 32%. So we are very much sure, pretty sure about that this patient is suffering from congestive heart failure or heart failure with reduced ejection fraction. Where you can see the liver imaging, we can see the grade 3 fat liver steatosis and steatosis severity with the fibrosis stage, and the diet is basically finding after talking to the patient probingly high sodium, refined carbohydrate, low fiber diet, poor protein distribution. So interpretations could be multiple MNT target. So already I have discussed about the LVA full form and the MNT. So this is altogether a case. Next slide, please. So we can see the analyte of this glycemia, that is fasting, and the PP we have seen. We have seen the lipid, LDL, HDL, and the triglyceride. We have seen the liver enzyme test. We have seen the protein context like albumin and the total protein. We have seen the inflammatory marker like CRP. We have seen the renal like creatinine, EGFR. We have seen the urine ACR. We have seen the electrolytes, and we have seen the heart failure biomarker, that is natriuretic peptide BNP or NT-proBNP, where the findings are fasting 168 mg by dl, PP 256 mg by dl, suboptimal control, Lipid is LDL 142, which is too high. 34 is the HDL, which is very low, which is not good for the patient. And triglyceride is 268 mg by dl, that is atherogenic dyslipidemia. And liver, AST 66, ALT 92, and GGT is 118 U by L. There's metabolic liver injury pattern. And albumin part is 2.8 gram per dl, and total protein 6.1 gram per dl. Low albumin. Yes, patient is suffering from the hypoalbuminemia. Inflammation, CRP is 9.6 mg inflammatory burden. When the CRP is high, we all know the pro-inflammatory cytokines will be higher, like IL-6, IL-8, tumor necrosis factor alpha, etc. Renal, 1.18 mg per dl is creatinine, and 73 ml per minute per 1.73 meter square, that is the EGFR. And urine ACR 68 mg per gram, moderately increased albuminuria. Electrolytes 137, 4.8, and magnesium 1.8, and heart failure biomarker is 1250 pg per ml, which supports heart failure burden, which is pretty high. Next slide, please. So the scientific differential why albumin is 2.8. Look, like based on the last two slides, what we have seen, this is a complex cardiometabolic patient where the heart failure with reduced ejection fraction, type 2 diabetes mellitus, grade 3 MASH non-alcoholic fatty liver diseases, metabolic dysfunction associated with liver diseases, hypertension, dyslipidemia, diabetic kidney disease, inflammation, protein energy malnutrition risks like sarcopenia, all we do in our hospital, like SGA, like MAST, like NutriQuiz score, all this kind of tool you are using. And such a patient requires an integrated medical nutrition therapy are very, where we can see the congestion of the diet, like expanding the plasma volume may lower the measured concentration. Congestions can increase the albumin without equivalent the tissue protein gain. So we can say very much sure about the less amount of the dietary fiber, where the dietary fiber was very less. So we are not detecting too much of their GLP-1, that is glucagon-like peptide 1, or gastric inhibitory polypeptide, or peptide tyrosine peptide YY, and we are not finding a good amount of the G-coupled protein, which is actually working with the dietary fiber and the proteinaceous part. So the ghrelin was much more higher, where leptin was much more lower, and patient is suffering from such kind of disorder where liver dysfunction, and simultaneously albumin must be interpreted with the INR, inclination normalized ratio, bilirubin, and the broader liver picture. So this is a multifactorial disorder where we can see lot of problem. The problem from the heart, the problem from the diabetes, like pancreas, the problem from the liver, everything are interconnected with each other. Next slide, please. So what about the ASPIN or ASPN principle? So albumin is not a nutrition marker. So states that serum albumin and the pre-albumin characterize inflammations more than nutrition status and should not be used as the proxy measures of the total body protein or the muscle mass. Here we are very much concerned about the muscle mass because we have seen the patient's diet was very poor, low protein mass, where patient was missing lot of branch chain amino acid, and that too for the leucine, where we all know very well where leucine stands for. Leucine stands for a very good mechanistic or mammalian target of rapamycin. It is the mTOR pathway where the GATO2, GATO1, cystine2 are very much interconnected with each other, where the muscle sensitivity is much more higher. But here we can see the muscle percentage is very poor, and malnutrition like muscle deficiency and protein deficiency is much more higher, and simultaneously reduce congestion, improve intake, and decline in inflammatory burden. So nutrition improvement must also be assessed through our intake adequacy, nutrition focused physical examination, so muscle function measures, and the dry weight trajectory. Next one. So this is the insulin resistance case drive the hyperglycemia, hepatic de novo lipogenesis. So we all know very well what is de novo basically. Sometime fructose is not going too much of far of this mitochondrial pathway and electron transport system with the cytochrome B pathway for the energy transmission. Sometimes hepatic de novo lipogenesis, lot of fructose can goes to acetyl CoA with the malonyl CoA, succinyl CoA, and increase lot of triglyceride. But the biochemistry we have seen, the present patient is suffering from the high triglyceride level and arthrogenic dyslipidemia due to higher LDL level, and hypertension about the neurohormonal activation increase after load and the adverse ventricular remodeling, and heart failure activates the RAS and the sympathetic pathways where congestion affects renal, gut, and the hepatic physiology. This is the biology. And the severe hepatic steatosis reflects the metabolic dysfunction, liver fibrosis must be staged separately. And inflammation, where you can see the CRP is bit higher, poor appetite, and congestion can coexist with the obesity and produce clinically important nutrition risk. Next slide, please. Where we can see this heart failure guideline, where we can see there is the ARNI and the RAS pathway therapy evidence of the beta blocker, mineralocorticoid receptor antagonist, and the SGLT2 inhibitor, because this is all under in the RAS pathway, where we can see the heart failure treatment predominantly with the gold standard with the enalapril, ramipril, all the ACE inhibitor. But nowadays the things has been changed. Nowadays the people are much more switched to of different combined salt, that is sacubitril and the valsartan, which is ARNI, that is angiotensin receptor of neprilysin inhibitor, because patient is on ARNI. And the dietitian must understand the regimen, because sodium, potassium, fluid, carbohydrate restriction, and the fasting practices can affect safety. Next point, next slide, please. So these are the medicines are going on for this particular patients in our hospital. By sacubitril, already I have discussed scientific detail, because volume BP changes influence the nutrition assessment. Valsartan, 81 receptor blockade reduces the maladaptive RAS effects. Monitor potassium and the renal trends, because we all know these are predominantly working in the distal convertible tubule. So this we have to be monitor potassium and the renal trends, and reduces the CV death and the HP hospitalization. So part of multitending of the GDMT and angiotensin converting enzyme inhibitor transition. No co-administration, 36-hour washout period. Sometimes doctor has given such kind of prescriptions of the ARNI and ask the patient to wait for the 36 hours after having the enalapril, which is the heart failure ACE inhibitor, but patient didn't wait. So this kind actually occurring the angioedema. So these things should be monitored. So medication reconciliation and the monitoring like BP, creatinine, EGFR, potassium, hypotension, angioedema risk. So avoid indiscriminate potassium supplements and the potassium salt substitute. So we have to see these are all about the drug nutrient interactions. Next slide, please. Already I have discussed about this thing, the illustrative concomitant medications. So patient is having the sacubitril valsartan, evidence-based beta blocker, spironolactone, aldactone, epilepron. This is all about the mineralocorticoid antagonist, dapagliflozin. So this is something SGLT2, loop diuretic is going on. Any kind of loop diuretics this patient is having. Metformin, biguanide kind of drug is having, and high intensity statin also going on, like HMG co-reductase is also going on simultaneously with the concomitant medication. So this is all about a dietitian's role, about blood pressure, potassium, renal function, BP, exercise tolerance, hyperkalemia, renal monitoring, volume status like ketoacidosis, precautions, daily weight, because in the heart failure we have to check the body weight, like 1 to 1.2 kg in weight increase in next day or next 2 days is very, very alarming, and 2.5 to 3 kgs in a week is also very, very alarming for the ascitic fluid, also pedal edema, and that can chance to goes to your pleural effusion or pulmonary edema. Daily weight, GI tolerance, B12 context has to be seen, because there is chances of the hidden hunger. We have to check these minerals and micronutrients parts simultaneously, and cardioprotective diet remains complementary has to be given to the patient. Next slide, please. So this is all about the medical interactions. Very low carbohydrate ketogenic diet are discouraged with the SGLT2 inhibition because of the ketoacidosis risk. And simultaneously with the ADA 2026 guideline recommended SGLT2 inhibitor for this prevention of the heart failure with glycemic management. So this has to be for the physician's role. We have nothing to do with these slides. Next slide, please. MASLD is a very important part. MASLD are I think battery is running low for the organizers short of. Yes, thank you. So grade 3 steatosis describes severe hepatic fat accumulation. It does not automatically mean the F3 fibrosis. Fibrosis risk requires separate validated non-invasive assessment, and the escalations were indicated. And the core treatment addresses obesity, type 2 diabetes, dyslipidemia, hypertension. Improvement in ALT, AST, or albumin does not by itself prove fibrosis regression. According to the ESPN guideline in the previous days, where for the hepatic encephalopathy or steatohepatic patient are being restricted for the high protein. Why? Because they told that the high protein means high amount of the nitrogen balance. If it is high amount of the nitrogen balance, that can increases of the ammonia NH3 from the liver, and it will be basically problematic for the kidney health. But nowadays, when the new paradigm shift has been turned to the NFLD and MSLD and the protein guideline from the ESPN, they said that 1.2 to 1.5 grams of protein per ideal kg body weight should be required for the patient is suffering from compensated, decompensated hepatic encephalopathy, NFLD and MFLD cases. Why? Because if it is a low protein diet, that will be happening of this high amount of the neoglucogenesis and can destructive ways can increase much more of the ammonia. So it has nothing to do with the protein. The protein should be in the optimum range and has to be given to the patient suffering from hepatic encephalopathy and steatohepatitis. Next slide, please. So this about the MNT, medical nutrition therapy, what we can approach and the rationale for the patients. So individualized, avoid severe restriction during poor intake or congestion because prevent worsening protein energy deficit. We don't want wasting. We don't want the high catabolism. We don't want something is a nosocomial infection, and we don't want something could be a patient hypotensive, a lot of other problem because the patient wasn't at point of time with the noradrenaline and also the vasopressure. So we shouldn't want these things also, and simultaneously no sarcopenia. So the protein approximately 1 to 1.2 gram per kg per day using appropriate reference weight, individualize, support adequacy, lean mass modify for the renal and the hepatic context, meal pattern, small frequent nutrient dense meals if the early satiety, congestive may reduce appetite because there are a lot of congestion that can reduce appetite. Why? Because this can activate our basically solitary status and our brain part. So this is the our hindbrain side, which is actually nucleus tractus solitaris to increase loss of nausea vomiting center activation. So in this kind of problem can occur, patient sometimes very anorexic, not willing to have anything. So sometime we can switch to the oral nutrition, to the enteral nutrition feeding and also the TPN, but we try to incorporate with the oral feeding too. Individualize, reduce major processed food sources, support BP, congestions management, fluid, restrict only when clinically indicated, depends on congestion, serum, sodium, and the heart failure plan, carbohydrate, control distribution, high fiber, minimally processed sources, improve glycemia without ketogenic restriction. So we have to give the dietary fiber, but again, if there is an bowel ischemia, if there any osmotic diarrhea can happen with the presence of the MCT, then we have to check, maybe we can switch to the LCT also. Next slide, please. So I think that was it of the slides properly. Now it's the quiz time. So, Saurav, I think they can participate the quiz program. So
Yes, sir.
can we see the questions, or they
So
can
let
see
me
by their
explain
own?
the overview how to join the quiz once again, since the many people have joined after we have started.
Okay, please, Saurav.
Okay. You need to use the same email which with which you have registered and joined this program for joining the quiz. Okay. So the quiz link has already been shared in the chat box, as you can see. You need to click on that, and the quiz link has also been shared to your email IDs. You can click from there or from the chat box. Once you go to the quiz platform, you need to enter your full name and also the registered email ID. After that, click on Join Slido. You'll get an access code. If it says invalid email ID, then you need to use the email ID with which you have registered this event. You'll get the access code. Enter that access code in here. Yes. On the platform, you will enter the access code and the name will be fetched automatically since you have already entered it in the beginning. Okay. You'll get the screen of get ready with your name. Yeah. I will start the quiz from here, then you can start attempting the questions. You need to use the same email ID with which you have joined this event, because the people who have registered with the email, they are using the same to join this quiz platform. So you can see people have 47 people have already joined. People who are saying that they are unable to join, they must use the registered email ID. Okay, so the quiz is going to start. You can see the first set of question on your screen here. You need to attempt it and click on send. Once you send, the quiz will log and the next set of question will be displayed on your screen. So the first 5 set of questions has already been done. Now, Aritrokhan sir, you can take over.
Yes, hi. I was on mute. Yeah, probably I think they have joined the
We'll
quiz.
start with the next session, Dr. Retro. Yeah, in the thing.
Yes. So, yeah. So next session, definitely we can start with it directly. So now what is this MNT phase 2? The phase 2 is basically the cardiometabolic and the hepatic optimizations where the energy balance and the outcome sought is a very, very important. What is the intervention? Now, moderate sustainable deficit after stabilization. That is very important. And the carbohydrate quality, we can go for the whole grain cereals instead of the refined carbohydrate. We can go for a good amount of the pulses, vegetable, and minimize free sugars. So sugar shouldn't be there. Sometimes they are finding lot of alternatives like jaggery powder, like honey, everything, but we should restrict all things are basically the empty calorie is coming from the sugar and the fructose. We shouldn't go for that much. So that is improve the HbA1c, triglyceride, and the hepatic metabolism. And the fat quality, replace saturated fat with the unsaturated sources. That is very, very important for the CVD risk reduction. Nowadays, apart from the LCT, we can do much more about the MCT, medium chain triglyceride. Why? Because medium chain triglyceride doesn't require any kind of pancreatic lipase and also the bile salts. So this is very easy to digest, about 6 to 12 carbons, caproic acid and all those things. So this is actually good for the fat digestions and the metabolism. So we can go for the MCT instead of the saturated fat or the LCT, and no trans fat. We shouldn't allow any kind of ultra processed or the processed or trans fat rich dietary sources. Protein distribution, we have to always check the pacing strategy. Spread high quality protein, definitely high biological value protein, good NDPcal percentage, good chemical score. So adequacy and the muscle preservation is very important, and we can emphasize lot of branch chain amino acids and less of aromatic amino acids like someone is unable to join. Anyway, aromatic amino acid like tyrosine, tryptophan, and phenylalanine. So that is very important. We have to mention the maintain the Fisher ratio, and the fiber increase gradually with tolerance. Not only in the high fiber diet very immediately. We can start with resistant maltodextrin, lentil carbohydrates. Gradually, we can increase the dietary fiber, and sodium literacy, level reading, processed food substitutions, and lower sodium exposure, and medically cleared progressive activity, function, and the insulin sensitivity. There is one activity we can use to say for the resistant training for the muscle. Like if you talk about the sarcopenia, then we have to do the resistant training. But here, this is unlike Fuller case where the heart failure occurred. So for the heart failure, we have to obey and the guidelines of New York Heart Associations. So for that, where the heart failure NYHA A, B, C, D in the percentage, what activity and how much activity is allowed, that should be discussed by a physician and the cardiologist. So that is very important that we have to obey and not to risk of the heart failure patient to walk at least 150 minutes per week. That shouldn't be true. Next slide, please. So Indian MNT translations. We all know this platter. We know very well there's plenty vegetables and the fruits, basically either rice, the cereals, at any point of India, staple foods. We are talking about North Indian rice. We are talking about South Indian staple foods like dosa, like idli, like appam, like curd rice. All those things are simultaneously are very, very important, but the platter should be a very good amount of the dietary fiber, very good amount of the salads, very good amount of the dal and pulses, everything in detail, and also the protein. We shouldn't miss the protein, and the water should be there, because water sometimes given an forgettable nutrient, but the water balance should be there. But for the heart failure patient, for reducing edema, there the water or the fluid restriction may be not more than 1.5 to 2 liter. Again, it will be disseminated by the treating physicians, because they have to check the fluid intake and the urine output. So positive balance, negative balance, either in hypovolemia, hypervolemia, and what is the dosage of the loop diuretics are going on. So that's depend on the fluid, but that part's definitely discussed by the physicians, and dietitians should obey that particular the fluid restrictions part. The breakfast vegetable oats, dalia, plus individualized unsweetened protein source, control whole grain protein and vegetables, and snack would be unsalted roasted pulse, nut portions. Another nutrient, dinner could be vegetable, individualized lean protein, controlled carbohydrate portion, avoid heavy late meals. So we have to follow the chrononutrition, the biological clock, and the circadian rhythm. So once we go for a too late night eating, our digestive tract, all the enzyme doesn't that much work properly. So in that cases, we do prefer low FODMAP diet, low FODMAP, low residue diet, and also the low resistance starch rich diet during the dinner. So dinner shouldn't be a very high compared to the lunch. but the breakfast would be the very ideal part that we can take adequately, not the dinner. Use complementary plant protein across the day and choose animal source protein if used according to lipid, sodium, renal and the cultural context. Yes, because plant protein have a good source of the branch chain amino acid, where if you talk about the animal source of the protein, where the methionine, where the cysteine, the sulfur containing amino acids are there, predominantly of the high amount of the aromatic amino acids. So we can get that kind of protein because animal protein are the complete protein. But the plant protein, you have to go for the combination protein because maybe you are missing the methionine from the dal, you are missing the lysine from the rice. So the rice, dal, khichdi, rice, dal, any kind of porridge, that could be the best option for mitigating all the diseases and incorporating lot of mixed amino acids, essential amino acids. Do not prescribe excessive protein simply to raise albumin. Correct total adequacy and underlying drivers. Again, albumin is not always we talk about the protein. If the renal problems is there or if the EGFR is very low, then we shouldn't prescribe too much of the protein for the sake of albumin. Maybe in hospital you can see where the intensivist or the critical care physician sometimes used to own us to give like IV human albumin. Okay, so in that cases you have to check about the albumin level and simultaneously you have to incorporate the albumin. If albumin low, it doesn't mean you have to prescribe lot of albumin supplements and the high protein diet to a particular given patient. That is very important thing. Next slide, please. Again, this is a quiz time. Please join the quiz.
Yes, the next set of questions will be started. You can simply click on the link once again or just switch the tab. You do not need to refresh or do anything. Once the quizzes will be started, you can start attempting. Okay. So the next question is about to start.
Thank you, Saurabh, and I think we can move on to the next final part of our presentation.
Thank you, Saurav, very much for operating such a nice way. Okay, so yeah, we can go for this albumin. So albumin, again, albumin trajectory during the comprehensive care. We do a lot of discussions about the albumin, but the baseline where the CRP is an high 9.6 mg per dl, interpretations, multifactorial low albumin, clinical context, we can found edema, poor intake, congestion, albumin 2.8 gram per dl. Week 2, we have seen the 7.4 mg by dl, where we can see early rise may include the hemo concentrations of these, improved intake and decongestion 3.0, little bit of elevated from the baseline to the week 2. And week 6, we have found 4.8 was the CRP was there, little bit of lower, and we can go for the concordant recovery, adequacy improved, edema reduced, and the albumin is 3.3 gram per dl. And the week 12, after the 12 weeks, the patient was admitted in the hospital for prolonged timing, where we can see CRP is little bit of, because CRP sometimes is not detected with the normal CRP. That's why our intensivist has suggested to do for the high sensitive CRP, where the 2.9 mg per L, where the normalized trend, stable intake, improved congestion, metabolic control, and we can see the albumin level is 3.7 gram per dl. So albumin trajectory is definitely improved with the proper comprehensive tailor-made care. So that is very important thing, that albumin is not only increases after giving the high protein diet. It's all over about the management from the intensivist, management from the critical care physician, management from the consultant, and also a critical care clinical dietitian for daily. So our daily update should be the patient's their bedside, because bedside clinical eye is a very important. You have to go always, because I have seen the patients, so many patients where the slate was going on, their noradrenaline was going on, so there are changes, because at the point of time, if the patient is on the nasogastric feeding, so sometimes you can go for the NPO. Again, we have to start at the feeding. It's not like that prolonged feeding can manage the patient, or immediately we can start with the high protein diet can manage the patient. It could be a slow progression, and the blood workup followed by a very important and sustainable subtle treatment for a critical care management is a multifactorial diseases. Next slide, please. So the medical diagram interpret with the intake, CRP, edema, and decongestion. A rising serum concentration is not proof of the isolated protein repletion. 2.8 baseline to 2-week 3.0 to 6-week 3.3 and the 12-week 3.7 gram. So basically we can decreases the CRP and increases the albumin level. This is a hypothetical case that we can improve through the diet, through the medical nutrition therapy to be more precise, and also the medical management by the physicians and the critical care intensivist. Next slide, please. So the 12-week integrated outcome dashboard win weight 92 kg with edema. Then after 12 weeks, 86.5 kg, edema reduced, fluid by the tissue change. BP 154/94. Now after 12 weeks, 124/78 by the conservative hypertension management with the medications and the diet. HbA1c 8.40. Now after 12 weeks, 7.20. Improved glycemic control. We have seen that their SGLT2 and the biguanide was on. Triglyceride 268 to 1676 mg per dl. Improved metabolic profile that we have seen, low fructose diet, and also simultaneously they have given a good amount of the statin. ALT, AST 92, 68, 58, 43. Biochemical improvement, not fibrosis proof. Albumin already have shown 2.8 to 3.7 gram per dl, improved during comprehensive care. CRP already have shown 9.6 to 2.9 mg per L, inflammatory burden reduced. Symptoms, NYHA already have discussed, that is heart failure classification 2 to 3 phenotype improved toward 2. So toward 2 means a little bit of exercises is allowed. This is about the clinical response, because heart failure, congestive heart failure is a disease or disorder. It is a prolonged chronic disorder. So immediately the changed of the patient's symptoms had said so many things. Their orthopnea, their nocturnal orthopnea, their dyspnea. This is very, very, very important. Patients sometimes feeling lot of fatigue, lot of shortness of breath, and also the kind of always sputum, cough, always, and also the weight regaining are very, very, very major and the classical symptoms for the HF-ref, heart failure reduced ejection fraction. So these things is agar symptomatically it can be managed. It will be a good manage for the patient. At least NYHA classification 3 to improve the 2 or 2 is the clinical response. So we can immediately gradually, if the treatment is going on, we can shift to the patient to the reduced ejection fraction to the preserved ejection fraction or mid-rate ejection fraction. So it will be a very, because I have so many patients are there nowadays. The patient was, kind of fighting with the, what I can say, the life and death. Now the patient is doing cycling. Cycling is own market, own shopping and everything. So I have changed 360 degree for a patient who was, fighting with the, their death and life. And now he is cycling, coming to my clinic, seeing us, doing regularly NT-proBNP checkup, Holter monitoring, their echocardiography with the color Doppler, ECG on the regular basis. Because this is something, because once I'm saying like clinical dietetics is not a one go. Clinical and critical care dietetics is a prolonged strategical management hand-holdingly, because indispensably this is very, very important nowadays. Nowadays we can talking about the NCHP, talking about lot of their commission. So this is a very, very important part. This is not only about your diet, what you go for the food service management for a hospital patient, but simultaneously you have to work hand-holdingly with the critical care intensivist, critical care physician, critical care nurses, and also the other technicians and all the people. It could be you can just go for a change where we can see this outcome after the 12 week of this kind of a patient. But that is very, very, very important. So our effort, a tailored made diet prescription, will change so many things. Next. So dietitian monitoring dashboards where we can see the monitoring weight, edema, dyspnea, BP advice, condition safety, and creatinine, EGFR, BP as ordered, because ARNI, they are spironolactone, aldactone, diuretic, loop diuretics was going on. Early MNT follow-up, because early initiation of the critical care nutrition is very important. Whether you can start with the oral feeding, whether we can start with the enteral feeding. Intake adequacy, appetite, sodium sources, GI tolerance, implementation, albumin together with CRP and the clinical context, avoid misuse as isolated nutrition marker, HbA1c, lipids, weight, waist circumference, functional status. Metabolic response is very important, because we all talked about that, because you all know that NASH become MASH. PCOD, PCOS become PMOS. So this is all about the metabolic syndrome. So metabolic syndrome is very important. AST, ALT, GGT, fibrosis path, renal profile, and talk about the hepatic and the renal trajectory. So these things, the dietitian monitoring dashboard is very important, because a few dietitians, because I do take a lot of internship or the program of the MSc Dietetics DFSM and a lot of other universities also, where I can always focus to my interns to read the blood workup, to read the medicines, to read the dosage, to read the TPN formula, to calculate the TPN formula, to read the what about the NAS, DNAs percentage, what the medication changes. Regular their intensive is update with the update file. And if you are not update, if you're not taking about the drug titration, you will not get to the point. If the patient is INR is high, if the patient is having warfarin kind of drug, or any kind of what I can say, like blood thinner or any kind of antiplatelet medications, what about the vitamin K? So all those things like drug nutrient interaction is a major phenomena, is nowadays a very, very important part that you have to monitor on the regular basis. And the blood workup if the patient is having this kind of drug like ARNI, like MRA, and the diuretic. And also that you have to check about positive balance, negative balance of the urine in detail about that from the file of from the daily chart. Okay, next slide, please. So selected evidence base where the ASPN positions paper, albumin, prealbumin reflect inflammation, should not be used as nutrition markers or prefers the total body protein, AHA, ACC, HFS, ACE28,000 heart failure guideline. Their foundation heart failure like includes ARNI, RAS pathway therapy, beta blocker, MRA, and the SGLT2 inhibitor, FDA like sacubitril valsartan, AC 36-hour washout period, MSLD guideline metabolic risk treatment, paradigm HF, DAPA HF, and the Emperor reduce. This is all about our drug detail with the guideline of their guideline sources. Next slide, please. So key scientific conclusions, albumin increased, already have shown. Sacubitril valsartan may be a key heart failure medicines within a multi-drug guideline directive strategy. Lot of concomitant medications was there. MNT integrates protein energy adequacy, sodium fluid context, glycemic control, lipid quality, liver health, and the lean mass preservations. Already we have discussed about the G-couplet protein, dietary fiber, and also the branch-chain amino acid. We're talking about the mTOR pathway like cystine 2 and the GATA2. Clinical dietitian must understand drug-nutrient interactions and recognize laboratory changes requiring medical escalation. And the most defensible case conclusion in the multidisciplinary improved intake, decongestion, reduced inflammation, cardiometabolic control produced, and the concordant recovery. You know very well that's, lot of adiposity, lot of adipose tissue sometimes are work as an active endocrine organ and increase lot of pro-inflammatory cytokines like tumor necrosis factor alpha, interleukin 6, interleukin 8, and mitigating lot of protein balance in our body. So we have to fight. We have to fight with the leptin ghrelin. We have to fight with this adiponectin. All those things in synergism with the MNT therapy and with the GLP, GIP, peptide YY, all this activation. So that is very important. You know very well nowadays GLP-1 RA receptor agonists are available. You know very well. I'm not talking about the name, but the semaglutide, tirzepatide are very, very, widely accepted and physician used to prescribe. But you know very well, we have our own GLP. We have our own GLP-1 in our body, but due to presence of that dipeptide peptidase 4, DPP4, we can't restore that GLP. But if your diet will be the proper with the resistant starch, linty carbohydrates, all those things, so gastric emptying and automatically increase our good dietary habit, reduce the ghrelin, and also increase the good amount of the leptin, adiponectin, such kind of a hormones, and actually maintain with the proper like hindbrain, and also the our appetite, reducing our appetite. So that is actually our own hormone. Sometimes there are a lot of drugs like incretin mimetics, like there are a lot of what I can say, sitagliptin, linagliptins are there with the drug. Maybe sometimes doctors used to prescribe, but with the diet we can easily, if our willpower has to be do these things also from the day zero, we can try to implement in our diet. We can do this paradigm shift by our own. Why always depends on the medications and other therapies. If our MNT says lot of things and we can implement with the guideline of the ASPN and ESPN, we can do it. Next slide, please. I think this is the last slide. Now the quiz time again.
Yes, sir. The last 5 questions will be displayed in a while. And the method is same to join the quizzes. They can simply click the link or just switch the tab. Ramesh sir is speaking.
Yeah, this is the last of the final quiz. I think this may decide the winner of this evening also. I think pay attention and then have your fastest finger first. Yes. Go ahead, Saurabh.
The 11th question is on the screen, sir. The 12th question is being displayed. Here comes the 13th question. The 14th question has started. Now we will move to the 15th and last question. All the 15 questions has been displayed and it has been attempted by the participants.
Yeah, Dr. Aritrokan says unmute me. Okay. Saurabh, yeah. Can we have the winners leaderboard displayed?
Yes, sir.
Shall we get the result right away, Saurav?
So you can take the Q&As and after that we can show
Okay.
the winners list.
Okay, sure. I'm very much excited because my lovely colleagues have joined from the entire India, and I'm very privileged to see all of them. There are a few known of me. We used to see each other, so I'm really glad to see that they have found their time, that they have joined in this busy evening. So very good to see. My heartfelt gratitude to all of you. Today is Guru Purnima, so my heartfelt gratitude to all of you. Yes, Sakshi, they will be announcing the winners, I think. Because this is very your day-to-day practice. You all know very well everything. Because in 8 to 9 hours in the hospital, you are walking with the doctors, you are doing your round. So you all know everything. This is something kind of a very learning and disseminating knowledge with each other. Thank you, thank you. I don't know your name, madam, but thank you so much. You all know everything. This is something I can just share with a case study from my hospital. That's the thing.
Thank you, Saurabh, for unmuting me. In the meantime, before they
Thank you, Dr.
announce the
Vashwati.
final results, is there any questions you would like to get it clarified from Dr. Aritrokan on the entire presentation.
Thank you, Afrin. Thank you.
Preen Ansari says it's an informative and an insightful session. The way you explained made the concept very easy. Fantastic. Thank you for that comment. It was indeed, Dr. Arithro was in-depth discussions primarily are presented on the cardiovascular disease as well as the cardiometabolism. Also, you had explained in detail the most important aspect, that is the drug-nutrient interaction. What are the various drugs which is primarily being used? Very nicely, you have explained many of them regarding the renin, angiotensin, aldosterone system and how the various drugs associated with that have a drug interaction in this particular regard. And I am sure your dietitian dashboard, whatever you have displayed, should be extremely useful for the participants in this regard, because very few presentations normally or very few discussions normally being conducted on nutrition in cardiometabolic or cardiovascular disease in this particular regard. You have nicely taken from the initial stages of hypertension, the one step below also you want impact glucose tolerance to hypertension to then taking them over to the cardiovascular disease and the various treatment regimen. It was really insightful, and I'm sure the audience would have significantly benefited from the overall presentation. And the presentation would be available, and we will be sharing to the people in this particular regard for much more in-depth learning, primarily for them. And it was a great honor that you coming on our platform and presenting an extensive and very passionately you did, Dr. Ritro, in this regard on the entire subject. And thank you very much. And we look forward for the winners. Now, lot of comments are coming in, Saurabh, on the line that who are the winners, will get.
Yes. So very exciting, and thank you so much for your lovely messages. I also enjoy, because if you people are there, my lovely colleagues are there, definitely I do enjoy. And Mr. Ramesh sir, I would love to share the reciprocate to the same thing, that Pulse Nutrition is definitely a very much empirical organizations what I have seen. So I love to find my time for joining over here. This is a very much insightful platform, and I tried to find a case from my hospital, and I've given the case only. Rest our lovely clinical dietitian have participated, and they have joined the quiz. So I hope so, because who is first, who is last, that is not the question. The question is that they have participated, they have joined, they have interacted. That is the main thing. So if anyone have any question, please feel free to ask me, because heart failure is my core subject, my research subject, and simultaneously have done so many patients with the heart failure with some organizations. I'm not showing the name of the organizations, but I have now more than 20,000 database of the heart failure patients that I have done also with the drug of sacubitril valsartan and also the other concomitant medications. So this is my core subject. So any question, please feel free to ask me. Thank you. I don't know your name, madam, but thank you so much. And all the madams, I think there are a few sir also. So female and the male, gentlemen and the men, my lovely gratitude to all of you. Email ID, I think my email ID or organizer's email ID, I'm not sure. Anyway, I'm providing my email ID. If you want to know anything, you can just feel free to mail me.
Sir, the leaderboard is going to be displayed now.
Yeah, I think take a minute, breather. Yes, go ahead, Saurabh.
Yes, sir. We have the leaderboard here on the screen.
Oh my God. Very congratulations. Congratulations.
He's the number one.
Very good.
Sai Chakra Dasa. Okay. And Rashika Gupta and Prachi.
I'm taking a picture of this.
Yeah. And congratulations, all the winners.
So first is Madam Ravin Kaur Anand. So can we see her if it's possible, or you can say a few words?
Yeah, I think the letters are very small. Saurabh, can you make it slightly bigger? People are not able to read, I believe, some of them.
And I really feel honored that you have presented and you have seen the slides. Thank you.
The
So
whole
Ravin Kaur
module,
Anand.
Dr. Arithro, is primarily done so that it is made more interactive and at the same time more attentive, primarily in this particular regard. And also they take home some important points for the regular practice in this regard. That's where we have tried this different model from a routine, webinar, and a QA session in this regard as well.
Yes. Ravin Kaur Anand, madam, if you please say something. Please unmute herself, Saurav.
Yes, sir. I have unmuted from my end. She can unmute and talk on.
Yeah, please. She's there probably. Anyway, the next is Bhashwati. I think Dr. Bhashwati Goswami. Bhashwati, if you want to say something.
Unmute.
Please unmute Dr. Bhashwati. Yes, Bhashwati. Please unmute Dr. Bhashwati. She wants to say something.
Yes,
She
sir.
is
We have unmuted. They can just
Uh,
unmute their mic and
please,
talk.
you unmute yourself, Bhashwati. Okay, yeah, say.
Thank you so very much, Dr. Arithro Khan sir. Today is a very special day. Today is a Guru Purnima day, and my Guru is here. And I don't know how to say thank you to Pulse NutriQuiz and Nutri Health Foundation also. I'm very much privileged, very much privileged and excited throughout the session. Not only learning, but also adrenaline rush is going on. How to fastest finger fast like the KBC one. So I really enjoyed, thoroughly enjoyed, and I dedicate the success or whatever you say to Dr. Arithro Khan sir. Thank you, sir. And thank you, Ramesh sir also and Saurav sir also for organizing such a wonderful and such a warming session. Thank you, and I'm looking forward to attend next sessions also. Thank you.
Thank you, Dr. Bhashwati. Thank you. A big clap for you. Okay.
Thank you.
So, Ravinkar Anand, madam, are you available? Can I hear a few words from your end, please? Because you are
Hi,
the
sir.
first. Yes. Hi, madam.
Thank you, sir. I was really not expecting to be the first one here. I thought कोई ना कोई तो होगा जिसके 15 marks आए होंगे.
Good. We are really enjoying that you got first. Very good. Congratulations. Heartily
Thank you.
congratulations to you.
Thank you so much.
Thank you.
It
And the
was a
third,
great session, sir.
yes. And the third one is Marnidi Masana Sai Chakra Dasa. I think she's a dietitian. Madam, are you
Yes.
there?
Yes, sir.
Yeah.
Good evening, sir. Myself, Mansa. I'm very much happy and thank you so much for this wonderful section, sir.
Thank you. You are from which part of the India?
From Andhra Pradesh, sir. Andhra
From
Pradesh.
Andhra Pradesh. Okay. Really great.
Thank you so much, sir.
Thank you. And next one is Rishika Gupta. Rishika, madam, are you there?
Yeah,
Yes,
she has
sir.
been continuously posting the messages. Yes, Rishika. Yes, please.
Good evening, sir.
Good evening.
First of all, the session was very interactive, like very educational on my behalf because I was not aware of this topic so closely. But after whatever you have shared, sir, it was like very knowledgeable and very interactive like I would again like to read on this topic and get to know more about this topic. So thank you so much for that. And again, it was all because of your session, like all whatever you shared, it was the result that I could score this, and within this short time I could answer these questions. So thank you so much, sir. I
Heartily
would again
congratulations.
like to
Rishika,
connect.
madam, you were from which part of the India?
Sir, I am from Dhanbad, Jharkhand.
You are from Dhanbad,
Oh.
Jharkhand. Very, very lovely. Congratulations, madam.
Thank you,
Congratulations.
sir. Thank you so much, sir.
And I think the fifth one is Prachi Gatani, ma'am. Prachi, ma'am, are you there?
Yeah.
Prachi, ma'am, are you there?
I doubt some of them are locked out, I think so, maybe.
I think probably. But
Probably,
anyway,
yeah.
I have seen Ramesh sir, I think a few seconds difference, like what Dr. Bhashkar
Absolutely.
said about the KBC like of that. So
Yeah.
there are lot of yeah. So short of all my lovely colleagues are asking, can they get their grades? Because grades are important in university days. Also, we are waiting for our grades because I was very poor in
In fact,
physics.
yes, Dr. Haritro, all the participants will be receiving the certificate. Okay, in this regard for participating in the nutrition quiz, whoever are registered primarily in this regard will get a certificate, and also a certificate for the winners also would be given to them.
Yes, and Rishika madam told ki can't wait for the next session. I think the thing is that here is something like of that we have just discussed. Accordingly, the slide has been discussed and the quiz been there, and you have answered the quiz. And there is no kind of any help because the time was very short. So whatever you have learned from the session, you just clicked it. So it is really lovely, and I am really enjoying. And whoever not the score is that I think there's a game of the timing only because timing is very short. So that is short of and Ramesh sir decisions about the timing. I am no one of the timing, but I hope many people have answered so
Because
many
many
questions.
options were given there, all they will have to is pick the suitable option. I don't know how many of them are noticed. At the end of each question, the answer was also coming as a quick flash
Yes.
for the people to really understand which would be the right answer. Of course, after completing that question, we have been displaying the answer also in this regard. So that is what will commonly happen. A question with the objective, how quickly, because all we respect everybody's intelligence. I think many would get it right. And the only way to differentiate is who is faster, primarily in this particular regard. That's where this quiz makes it even more interesting, primarily.
Very good. Very good.
Okay. Thank you very much, Dr. Haritro. It was a wonderful and an interactive session. And would you like to have you back with a different topic subsequently on a different time on a webinar? We'll totally inform you on that. And thanks for all the support. And I'm sure all the audience, the way they have responded with a very positive feedback, have highly enjoyed your session. Thank you very much.
Thank you
thank
so
you,
much.
audience. And I would like to thank Saurabh, Swashika, and my entire team who is there in the field who have coordinated
And
along with.
before ending up, Mr. Ramesh sir and my lovely dietitian colleagues and all the organizers, I love to thank my heartfelt thank to Mr. Shaurav. From the day one, he was asking for the slides, for the question, kept on calling me, messaging me, sir, please give me the slides, give me the questions and all those things. So big good round of applause for the Shaurav and his team. I don't know the other people also.
Yeah.
So Shaurav and
Thank you, sir.
very,
Thank you
very
so very
lovely
much.
your presentation. And I love to my heartfelt gratitude to Dr. Mr. Kiran Das sir because Mr. Kiran Das sir called me and he made the strategy, made that. And that time I was asking what I am doing. I think, am I eligible for doing this? I was very much skeptical. But anyway, it was a great success mean everything. What does the end is success mean everything's got a success. And from your message, from my lovely colleagues' message means a lot and I am motivated. Thank you so much.
Thank you so much, Dr. Haritra Khan. It was wonderful. I'm sorry I had to step out in between and I had some other priorities, but I think the response with all the participants are very good. And we've seen the leaderboard. The statistics will be out as to how many people have scored beyond a particular level, and everybody would be getting their certificates with the scores on the certificate. So that would be something they can appreciate as well. So a wonderful session, and I look forward to engaging with you furthermore in such academic sessions. Thank you, Ramesh, for all the
Thank you,
support. Thank you,
Mr.
Saurav
Kiran.
and team, and thank you, audience, for having been such a patient and wonderful audience for this session.
Good night, everybody. Good night.
Good night.
Thank you. Good night. Bye-bye.